Thank you and good morning. I want to personally thank Jim Epstein and Rob Coleman for having me today. These are exciting times. I'm here to tell you that we did it. We did it. What did we do? Yeah, right? So it's been 8 years since we've brought you a new FDA-approved drug in ovarian cancer. 8 years. And I'm here to talk to you this morning about two new ones. And in fact, and Dr. Coleman, Rob had a lot to do with that. And you know what else we did? We brought you, our specialty brought you paclitaxel in 1992. Okay, ovarian cancer was the pathway to paclitaxel into oncology, and now this is one of the most common chemotherapy drugs used in solid tumors. Well, one of the FDA approvals that I'm going to talk to you about is a PARP inhibitor, a new entity, okay? And you will see that PARP inhibitors will resonate throughout the solid tumor space. So we don't do very many good things, but I think Rob and us, those were significant accomplishments, bringing you paclitaxel and hopefully ultimately bringing you PARP inhibitors. So these are my disclosures. They're printed in the outline. I'm going to talk about angiogenesis again over and over, but I think it's now in context. I think the story's over, okay? We're going to talk about PARP inhibitors. The story is just beginning. I'm not going to talk about immunotherapy too much, but that is the third generation. And I think as we continue to do this conference, we'll share with you immunotherapy agents, and I hope that we can bring you other immunotherapy agents other than the checkpoint inhibitors, which you're so familiar with. So we have a group of groups. It's called the Gynecologic Cancer Intergroup. Our group, of course, is called the GOG. We now call it Energy. And that group of groups is called the Gynecologic Cancer Intergroup, and it sets standards, and they'll meet again in November in Japan. So this is now 5 years old. And at that time, okay, they said that optimal reduction, optimal surgery is no gross residual disease. So Rob presented this case. The first thought I had when I saw that intraoperative photo was, should have given her neoadjuvant chemotherapy. Leaving all that cancer behind was not optimal, okay? And then the systemic treatment has been Q3-week carboplatin paclitaxel, but there are 3 options, and this has not changed a lot. You can give dose-dense weekly paclitaxel. We'll talk about that a little bit. You can give intraperitoneal chemotherapy, and certainly a biologic, and called Bevacizumab. So this is the evidence here that complete resection has to be the goal, and there is nothing optimal about leaving cancer behind. So this is the progression-free survival with complete resection, and the difference between 1 to 10 millimeters or greater than 10 millimeters in residual is very, very small, whether you're talking about time to progression or overall survival. So don't feel great when the gynecologic surgeon says, I got 98% of the tumor. What you should say is, oh man, you left a lot of cancer behind, okay? So at this same meeting 5 years ago, they said the most promising targets in the future therapeutic approach were anti-angiogenesis, anti-VEGF. We now have other targets. I'm not going to talk about them, but angiopoietin 1 and 2 is an example, and PARP inhibition, okay? So these are the 2 trials. I just want to put them into context because one of the options in your case was frontline bevacizumab. Published in the New England Journal, okay? It's been 4 years. And this was done at a time when we thought that chemotherapy had to be added to bevacizumab. It's the way it works in lung cancer, right? It's the way it works in colorectal cancer. You don't use bevacizumab as a single agent. And so this really was the intervention arm, this long maintenance phase. And this maintenance phase was for 15 months, and it was at 15 milligrams per kilogram every 3 weeks. And I can take some blame here, erred in making the endpoint for this trial an increase in CA-125. Rob was trying to bait you on that case. Well, what do you do if the CA-125 goes up? Well, it's a good question. We'll talk about it as we discuss that case. So these are beautiful curves, okay, with a difference of 3 months, or almost 4 months in progression-free survival, but it's based on CA-125. If you would have censored the CA-125s, then the difference would have been 6 months. And I think this led to some of the confusion, some of the approvals. 4 months of PFS, what does it mean? Okay, no overall survival, good point, okay? Well, maybe there is an overall survival. there's this concept that the patients with the largest volume disease, those that have greater than a centimeter residual or stage 4 disease, might have a survival advantage when bevacizumab is added frontline. And this is that same study. This is an ad hoc, stage 4, an 8-month improvement in overall survival in those patients. So I'm going to show you the other study published in the New England Journal that suggests this as well. So I get it that it's ad hoc, but since the findings are consistent across trials, it makes us wonder. So this is the second trial. Bevacizumab was at a lower dose, 7.5 rather than 15. It was not placebo-controlled. And the bevacizumab was for a shorter period of time, 12 months, not 15 months. And the progression-free survival looks promising. No difference in OS. And this is that high-risk group, large volume disease in stage 4. This is PFS. I want to point out to you here, though, that the largest treatment effect, the biggest difference in PFS, was at 12 months, right when you stop the bevacizumab. So the duration of bevacizumab is important, I think. I don't know what the right dose is. I'm not even sure I know when to use it, but I do know that duration is better. And again, this second ICON 7 study was at 7.5 milligrams per kilogram. No difference in OS here, but in that high-risk subgroup, there is a difference, just like the stage 4 patients in GOG 218. And the difference here is about 8 months as well, okay? So in large volume disease, I tend to use bevacizumab frontline, okay? 9 months. So these studies led to the approval in Europe. I get it, Europe is different. When I talk about PARP inhibitors, I'm going to compare and contrast the way PARP inhibitors are used in Europe. But the GOG 218, the 15 milligram per kilogram every 3 weeks for 15 months, frontline with maintenance, led to the European approval. But the ESMO guidelines said that maybe you should use 7.5. And maybe you should do it in these stage 4 large volume disease where there's a survival advantage probably. So why is it important? We don't live in Europe. Well, I want you to know that these are rational people, okay? And we now have bevacizumab FDA approved. I'm going to talk about it. But it's very rational to use it frontline, particularly in the large volume residual patient. So when patients recur, okay, frontline is different. Because in recurrence, patients can't be cured, right? So in that patient where the CA-125 is rising, you should think, wow, she feels great. And all of those choices are going to make her feel not great, okay? And now in today's world, we have 11 drugs now approved in ovarian cancer, 11. You can die of ovarian cancer 2 ways. You can die because you're overtreated and burned out and your bone marrow is worn out. You got such bad neuropathy, your performance status is terrible, chronic renal dysfunction, or you can die from drug resistance. And we are having more and more patients who are dying because they've been overtreated. So in treating recurrent ovarian cancer, I was saying, you got to make sure that you don't treat the patient too early. I get it. You got to make sure that you don't treat her too late, because treating her too late means she might get a bowel obstruction and you can't rescue her. But be very careful about over-treating your patient, because patients with recurrent ovarian cancer can get 5, 6, 7, 8, 9 lines of therapy, but only if you are thoughtful about the long-term toxicities. So this is the traditional treatment paradigm, but generally for symptomatic patients, okay, that in less than 6 months, a non-platinum agent, and it's really 3, weekly paclitaxel, pegylated liposomal doxorubicin or topotecan. I don't know what the activity of weekly paclitaxel is in platinum-resistant disease when you got a frontline, okay? When I say weekly paclitaxel is a good agent for recurrent disease, that's generally when the patient was treated with Q3 week frontline. In the sensitive space, it's a platinum doublet. Again, these are generally symptomatic patients. And the second drug that's added to carboplatin is either paclitaxel again, gemcitabine, or pegylated liposomal doxorubicin. And the gemcitabine was the last drug to get approved in 2006. And that's why I was so excited, because we got 2 new drugs in 2014. So this is platinum-resistant disease. This is the study that led to the FDA approval. I don't want you to look at this and say, well, all I got to do is do a trial with 330 patients that's not placebo-controlled and get a little PFS, and I can get FDA approval. This was an attempt, probably, by the FDA to harness the broad use of bevacizumab. Bevacizumab was being used in almost all ovarian cancer patients. The manufacturer of bevacizumab, their brand, they didn't like it because it was uncontrolled. There was no label. So there's a lot of politics that went into this small study. And again, this is chemotherapy, the 3 agents in platinum-resistant disease, weekly paclitaxel, POD, topotecan, with or without bevacizumab, and showed a 3-month improvement in PFS. It's pretty good. Published since the last time we spoke, published in May, okay, and no improvement in overall survival, again. And 8 days later, after it was published, the NCCN guidelines says it's a level 2A. Okay? The NCCN generally doesn't opine until the study is published, right? So any of these 3 agents with bevacizumab. It was submitted to the regulators. There was no ODAC, okay? There was no discussion. I told you why, okay? Because this was an attempt, bevacizumab was already being used to begin to have a label for the FDA to monitor it, and on November 14th, it got FDA approved. So this is the label. In my mind, it doesn't restrict it at all. I'm not sure that insurance companies always say, well, you can only use it here. So many of us continue to use it frontline in the select patients that we described, okay? And in fact, we sometimes use it in platinum-sensitive recurrence. In platinum-sensitive recurrence, the phase 3 trial was with carboplatin gemcitabine. Why? Because carboplatin gemcitabine was approved in 2006. So this is a randomized trial taking the last platinum-sensitive chemotherapy doublet, adding bevacizumab, and improving progression-free survival. Now I want to teach you here a little bit about what it's like, again, to have ovarian cancer in 2015. So this was the 2006 FDA approval. This was carbo alone, and this was carbogem, okay? This is now carbogem, same PFS curve, but we added bevacizumab to it. So this is what you get for carbo alone, this is what you get when you add gem, and this is what you get when you add bevacizumab. You say, great, look at that, okay? You get about 4 to 5 months every time you add a new agent. It's interesting. Well, it's not that interesting because you don't improve overall survival. I don't think that's true. You don't improve overall survival when you look at this in isolation, when you look at this one study. But if you look at the patient populations that we have, over time, patients with ovarian cancer are living longer today. So this is the overall survival from the first study, the 2006 carboplatin versus carbogem. Well, this is the overall survival from the bevacizumab study. So the same arm, carbogem, here, had a survival there, and now the same arm, carbogem, here, has the survival here. So there's an overall survival creep. This is a slide that Rob loaned me, gave me. Maybe I stole it. But this is really interesting. Patients today in platinum-sensitive relapse live about a year longer. And that's why progression-free survival is the best endpoint for clinical trials and not overall survival. So I can't show you one intervention that causes patients to live longer, but I can show you that when the PFS is the same, overall survival in today is different than it used to be. So let's talk about PARP inhibitors. So PARP, if I'm sure you know, PARP repairs single-stranded DNA breaks. So if you inhibit that, those single-stranded breaks become double-stranded. And those double-stranded breaks are repaired through homologous recombination. And homologous recombination repair deficiency, BRCA, then leads to cell death. So there are 2 ways that you can have this apoptosis. This synthetic lethality, where basically the DNA repair mechanism spins out of control because the single-stranded breaks due to PARP inhibition become double-stranded, and then BRCA patients or other homologous recombination repair deficient cells can't repair it. You can also add it to chemotherapy and potentiate it, I get it. But generally, these are agents that are used alone. Published in the New England Journal, okay, phase 1, very dramatic. And we've made a lot of progress here in a very short period of time doing phase 1, phase 2s in BRCA patients. And I'm here to tell you that it also works in BRCA wild type. Why? Because there are other homologous recombination repair deficiencies, the Fanconi anemia pathway, for example. So I'm going to talk about these two studies, Study 19, which is the label in Europe. It's different than what it is here. And this phase 2 in fourth line and beyond. Why fourth line? So this idea of platinum resistant and platinum sensitive, that's a really neat idea. We can understand it, but it's only second line. By the time you get multiple lines of therapy, patients, some are sensitive, some are resistant, but the toxicities and her unique aspects really make platinum resistant and platinum sensitive irrelevant. So Rob and I and our friends have tried to convince the FDA that this is another unmet medical need. The high unmet medical need used to be platinum resistant. Now it's heavily pretreated patients, and we drew a line in the sand, fourth line and beyond. So this is the European label, again, published in the New England Journal 2 years ago. These are patients who have platinum-sensitive disease, get chemotherapy, and go into remission. Happens all the time. And that platinum sensitivity is a marker for BRCA-ness, or homologous recombination repair deficiency, and those patients are ideal candidates for a PARP inhibitor called olaparib. I always use generic names. I'm going to use the trade name here because I want you to know it is called Lynparza. Lynparza, okay, Lynparza, okay? And it's FDA approved and available. So in unselected patients, BRCA normal, BRCA mutation, there was a doubling of the progression-free survival when used for patients who were in remission a second time, second or third line maintenance. Now I need you to get to know these agents and their class effects, just like taxanes cause bone marrow suppression, alopecia, neuropathy. They're a little different, the taxanes. Well, the PARP inhibitors are a little different, but they are class effects. And just like GI perforation is the Achilles heel for bevacizumab, the Achilles heel for PARP inhibition is GI, okay? Nausea, diarrhea, dyspepsia. And then like any chemotherapy causes fatigue and bone marrow suppression. Some cause more thrombocytopenia, some cause more anemia. Olaparib causes anemia. So anemia, dyspepsia, GI, and fatigue. So these are the patients who have BRCA mutations. So it works in patients without BRCA, but also it works better with BRCA. Hazard ratio of 0.18. This is the label in Europe. Germline mutation BRCA carriers or somatic, and platinum-sensitive relapse maintenance therapy. That's the European label. This is the difference in the patients who have non-mutations. So it's a 0.53 in wild type. It's a 0.18 hazard ratio in mutations. And there's even a trend towards survival, but it was a small study. And there are other PARP inhibitors, and you're going to hear about it. And every time you come to Las Vegas, we're going to tell you about them, okay? And the olaparib program is called SOLO. There's SOLO 1 and SOLO 2 and SOLO 3 and SOLOIST. There's the NOVA, which is niraparib. There's rucaparib, which is made by Clovis. And these are all in this maintenance setting, okay? There are other settings too, but this is the most common. All right, so we didn't get that label in the United States, but we got this label. This was just published last month in the JCO, and these are olaparib monotherapy in patients with advanced cancer, okay? All sorts of cancers. There were ovarian patients, breast cancer, pancreas, even prostate. And you'll find this, that there are other types of cancers other than breast and ovarian that have BRCA, and you can give them olaparib, okay, off-label. But we've brought that medication, that option to you. And there were 193 patients in the ovarian cohort, and you can see that the tumor response was 31%. So I'm going to hone in on this. But that single-arm, open-label trial led to accelerated approval. As you look at hematology and other settings, accelerated approval is a common, fast path to bring new agents to your cancer patients. It requires due diligence and confirmatory trials, and that's the SOLO studies that I was telling you. So it's now been 4 months since December 19th. And this is the label. So there were 300 patients treated like that, but in that study, there was 137 that I said, but they needed to have measurable disease, okay? And among the measurable disease, the response rate is 34%. Fourth line and beyond. 3 prior regimens, germline BRCA mutation carriers, 34% response rate with the GI toxicity, bone marrow suppression, and asthenia that I described. So this is the label: deleterious or suspected deleterious, not variants of undetermined significance, deleterious or suspected deleterious, and there is a companion diagnostic that's made by Myriad, BRCA analysis CDX, although we are getting olaparib reimbursed with other BRCA tests. I'm not sure it really matters. 3 or more lines of therapy, and the recommended dose is 400 twice a day. It's tough. They're 50 milligram capsules. You got to take 16 capsules a day, 8 in the morning and 8 at night. The solo trials that I talked about have a tablet, but this was the drug that the formulation that they used in their initial trials. So I'm just going to finish here, because why don't we do anti-VEGF and PARP together? That's what I do. I write clinical trials, so does he. So this was at ASCO last year, taking olaparib with an anti-VEGF agent, cediranib. Cediranib is not a molecule that you have in the clinic, but it's very similar to pazopanib and the other oral anti-VEGF TKIs. Small study, platinum-sensitive relapse, PARP inhibitor, cediranib, and olaparib. So PARP, and VEGF, and look at that. Pretty neat. Olaparib and cediranib, PARP and VEGF was pretty remarkable. And look at these response rates. An 80% response rate in platinum-sensitive relapse. That's as good as Carbogem-Bev, okay? It's really, really interesting. The future, at least in ovarian cancer, is non-traditional cytotoxic chemotherapy combinations. Anti-VEGF and PARP inhibition. And you'll see that resonate through other solid tumors. And the patients, this was an open label study, a mutation and non-BRCA mutation. In the patients that had BRCA, olaparib's enough. Because remember, BRCA is a marker for a predictive biomarker for activity. But in BRCA wild type, you probably need anti-VEGF and PARP inhibition together. So again, in platinum-sensitive relapse, you'll see what's the best treatment. It'll probably, some may be, if they're BRCA mutation positive or biomarker HRD positive, single agent PARP. Yeah, platinum, it's too much work, okay? Just take a pill. But if you're not positive, let's add some VEGF to it, okay? So that's what we're doing within the energy oncology group. In platinum sensitive, we're going to do this. Olaparib alone, olaparib, cediranib, but we're going to compare it versus chemotherapy, okay? We're going to try to move this forward. We don't want to give Carbogem anymore. We don't want to give Carbo-PLD anymore, okay? We want to give oral targeted therapy. And why don't you just add it to Bev frontline, okay? So that's what Genentech, Roche, and AstraZeneca, the maker of olaparib, are doing. This is the label in Europe, Bevacizumab based on GOG 218, maintenance Bev with olaparib or placebo. So you have the patient that we talked about, maybe the stage 4 large volume residual disease. You want to give her frontline Bev and maintenance. Well, here you can enroll that patient on this study and give her not only Bev, but maybe Bev and olaparib together. So this, you'll hear us and me talk more and more about targeted therapy combinations. So there you go, 11 drugs, 2 of them in 2014. Bevacizumab, okay, in November, olaparib in December. Thank you very much.